Thank you. Yep, as Dr. Meyer just said, I work for Johnson & Johnson. And our vision is to actually create a world in which we no longer live with HIV. And one of the ways in which we're working to do that is to create a prophylactic vaccine that will protect against all of the globally circulating strains of HIV. More specifically, this would be a 4-dose heterologous vaccine regimen that uses Ad26 viral vectors to induce broad cellular and humoral immune responses. And these vectors encode mosaic HIV antigens that are designed to cover the globally circulating strains of HIV. And the third and fourth vaccinations also include trimeric GP140 envelope proteins, which we see boost the cellular and humoral immune responses to vaccination. To put the study I'm going to describe in a broader context of our clinical development study, the first in human study for these types of heterologous regimens was performed in Approach, from which this same type of 4-dose adeno-based with GP140 regimen was selected. This regimen was then further refined in the phase 2A study, where we moved from a trivalent adeno, which was tested in Approach, to a tetravalent. That tetravalent-based regimen was then brought into the phase 2B Imbokodo study. The next regimen refinement was then to move from a single GP140 to test in the ASCENT study whether a combination of 2 GP140s would give an expansion of the immune responses. And the results of the ASCENT study would select the regimen that was going to be brought forward into a global phase 3 efficacy study. So to put these results then in a context of when you looked at expanding from a single antigen to other, we previously performed the TRAVERSE study, which was a similar randomized parallel group placebo-controlled study testing 2 different regimens. And here we compared the trivalent regimen, which was selected as the lead regimen coming out of the Approach study, and changed the composition to add an additional envelope component to go from a trivalent to a tetravalent adeno. And the results of this showed that there was a significant improvement across clades for both the humoral and cellular immune responses. So right here we have the ELISA and the binding and functional humoral immune responses, but we saw similar expansion of clade C specific responses and an expansion of the globally specific T-cell responses in ELISpots. So in preparing for phase 3 efficacy studies, we wanted to make sure that we had the best possible regimen. So we saw that going to a tetravalent adeno with a clade C GP140 induced superior magnitude of cellular and humoral immunogenicity. And we saw that moving from a monovalent envelope to a bivalent Ad26 increased the breadth of immune responses. So we wanted to then evaluate if we could further expand the global coverage. And the way that this would be done would be to add another vaccine component and maintain the tetravalent Ad26, but then split the clade C GP140 dose in half and replace half of it with a mosaic GP140. So the MOS1 GP140 has a better coverage of clade B circulating strains, while the clade C will complement that. And because it takes a long time to prepare for a phase 3 efficacy study, the manufacturing for the drug products that were going to go into this study had to begin even before the first in human data were shown from the mosaic protein. So this was a big risk that we thought was motivated by the preclinical data. We thought that there would be a good reason to switch to the bivalent protein, but nobody knew how it was actually going to work out ahead of time. So we performed the ASCENT study to see how that would actually would turn out. And similarly, this was a randomized parallel group placebo-controlled double-blind study to assess the safety, tolerability, and immunogenicity of these 2 heterologous regimens. There was 25 people who got the reference regimen, so that's the same one that was selected from the TRAVERSE study and the regimen that's being in the phase 2B Imbokodo trial. And then 100 participants received the same tetravalent MOS4 adeno, and then the bivalent combination of the GP140s. And the data that we're going to look at today are those through the complete vaccination series and the peak immune responses after the final vaccination. There's a follow-up period and then a long-term extension for the active arms of the study. So the primary objectives of this study were to evaluate the safety and tolerability of the regimens, as well as to compare the envelope-binding antibody responses. Secondarily, we wanted to compare the cellular and other humoral immune aspects of the humoral immune system. And the study was conducted in healthy adults aged 18 to 50 years. 152 people were randomized and vaccinated. Slightly more females than males were enrolled. And the study was conducted in the US, Kenya, and Rwanda. So to summarize the overall safety, both vaccine regimens were well tolerated through week 52. That's the follow-up period for the solicited adverse events after the final vaccination. There was no related SAEs, no deaths or HIV infections. And when you compare the two regimens, there was no difference between the active groups after the third and fourth vaccinations when they received the differential proteins. So the first thing we wanted to rule out in terms of the immunogenicity was that there was no attenuating effects to the clade C specific responses by removing half of the clade C GP140. So in the green dots are the bivalent regimen, the blue dots are the clade C alone, and we can see that both after the third and after the fourth vaccination, there's equivalent immune responses induced by both regimens. So that was the first bar we wanted to pass. But we didn't just want to have comparable data. We wanted to see that there was whether there was actually a benefit of moving from a monovalent to the bivalent protein. And by being able to pool the clade C alone regimen data from the TRAVERSE study with that from the ASCENT study, we can have approximately 80 people with a bivalent compared to over 100 with the clade C alone. And we can see that so the clade C responses are maintained, and the geometric mean ratios then of the clade B and the mosaic 1 ELISA responses are enhanced. The consensus C is also enhanced, and the clade A responses are similar between the two regimens. We also know that the IgG3 specific, the subclass of immunity is very important in HIV, so we wanted to make sure that there's high rates of IgG3 induced, and we see here the 1086, which is a clade C envelope GP140, that there's near universal induction of IgG3 for clade C, and this is similar between the two regimens. To explore more broadly the binding antibody breadth, we looked at the humoral responses against panels of envelope antigens that represent the global diversity. So using the binding antibody multiplex assay, first on the left looking at the GP140 antigens, we see that the green lines, which represent the bivalent regimen after the third and fourth vaccinations, are shifted either to the right, so they have a higher intensity, or up, which is a increase in the breadth of the immune response across these global indicator panels. For the V1, V2 antigen specifically, we see that there's a similar response after the third vaccination between the two regimens, but after the final vaccination, there is an increase in the coverage of the bivalent regimen. When we then expand this even further and look at 32 envelope antigens, which cover the global envelope diversity shown on the right, we see that a similar pattern. So there's certainly never any attenuation of immune responses within the bivalent regimen. And we see that after the final vaccination, there's an expansion under the magnitude breadth curve of the bivalent response for binding antibodies. So we know that binding antibodies are very useful, but they're probably not a mechanistic result. So we wanted to see whether the antibodies also had appropriate mechanistic properties. So we evaluated the antibody-dependent cellular phagocytosis response, first for the clade C GP140s, like we did with the binding antibodies, and we see that there's 100% response rate for the bivalent regimen, very similar to what we have for the clade C alone, and after the final vaccination, these responses are further increased. When we look at the breadth of the functionality responses, we see that for both clades A on the left, B on the top right, the mosaic, and the consensus antigens, there are broad ADCP responses with at least 90% response rate for all of the antigens after with the bivalent regimen. So when we then shift from the humoral immune responses to the cellular immune responses, we wanted to see how did the T cells react to the change in the protein composition. Here we're looking at the interferon gamma ELISpot for the mosaic 1 peptide responses on the left and the mosaic 2 envelope responses on the right. We see in both cases that there is very high frequency and approximately 450 ELISpot responses between both regimens and after both time points. So the MOS1 peptides have a better coverage of the clade B-like strains of HIV, while the MOS2 peptides have a better coverage of clade C. We also then looked at the PTE peptides, which have a global coverage and seek to cover as many strains as that you can globally. And we see that between the two regimens, there's still a very high magnitude of envelope-specific T cell responses induced, and this is consistent both after the third and the fourth vaccinations. When we dissect the cellular responses a bit further and we look into whether these are CD4 or CD8 mediated, we have ICS data for interferon gamma or IL-2 responses to the MOS1 peptides here, and we see that there's an increase in both the magnitude and the frequency of the CD4 T cell response in the bivalent regimen compared to the clade C alone. So you go from 50% response in the clade C regimen up to an 80% response with the bivalent regimen, and the magnitude of those CD4 T cell responses is approximately doubled. The CD8 responses for the GP120 are relatively low in both groups and consistent between the two regimens. When we look at the clade C responses then, to make sure that there's no trade-off between when we see an expansion in one direction, do you have a trade-off in the other direction? No, we still don't see that here. It seems like just a benefit from having the additional vaccine component. There's approximately half of participants have a clade C CD4 response specific for clade C GP120s, and that's similar between the two regimens and consistent between the two vaccinations. Like for the MOS1 peptides, the CD8 responses for GP120 are quite low. So to conclude on these results, we see that both vaccines are well tolerated. The bivalent regimen is globally relevant. Responses are present to almost all the circulating strains that were tested, and it induces broader immune responses compared to the clade C alone. There's an increase in the mosaic envelope-specific CD4 T cells, and the clade C responses, both for humoral and cellular immunity, are not attenuated by the improved clade B and mosaic-specific immune responses. So based on this, the tetravalent Ad26 MOS4 and the bivalent GP140 regimen has been selected to move into the pivotal phase 3 efficacy study, Mosaico. And I'll just spend 1 minute describing the Mosaico study, which is HVTN 706 and HPX 3002. And this is going to then test the regimen that was selected from the ASCENT study to be administered to 1,900 individuals. 1,900 participants will also then receive placebo in a 1-to-1 randomization, and they'll be followed up for 24 to 30 months, after which the primary analysis will be evaluated. So I'd like to just stop and thank all of our collaborators and partners. Without them, this would not have been possible. Also our Janssen compound development team, our management and our leadership, but also specifically to the clinical study investigators, all their site staffs, the volunteers who participated in this study, because without you, this clinical program would not be where it is today. Thank you very much.